All right, let's jump right in and demystify a topic that is just so critical for anyone in medical coding: colonoscopy CPT codes. Getting these right is absolutely essential for reimbursement and for compliance. So let's get straight to it.
So let me ask you something. Picture this. A patient comes in for a totally routine screening, but during the procedure, the doctor finds a polyp and removes it. In our world, the coding world, how big of a difference does that make? You might be surprised.
The answer, well, it could be the difference between five different CPT codes. And that one little shift from just looking to doing something is exactly why this topic is so important. The devil, as they say, is in the details.
To help us break it all down, here's our game plan for today. We're going to start with that first huge decision point. Then we'll walk through the basic and the more advanced codes. After that, we'll cover the supporting services like anesthesia, talk about the special what-if scenarios with modifiers, and we'll wrap it all up with the thing that holds it all together: compliance.
Okay, first up, this is without a doubt the most critical fork in the road. It's the decision that dictates everything else that follows. Was this procedure a screening or was it diagnostic? This right here lays it all out. It really comes down to one question: why is the patient here? If they have no symptoms and it's purely for prevention, you're on the left side in the screening column. For Medicare, that means you're using G codes. But the second there's a symptom or something abnormal to investigate, bam, you jump over to the diagnostic side, and now you're in the 45378 series of codes. This one choice changes your entire coding path.
Okay, now that we've made that crucial first decision, let's start building out our coding toolkit. We'll begin with the basic procedure codes, the real foundation for any diagnostic colonoscopy.
And here it is, the cornerstone of diagnostic colonoscopy coding, CPT 45378. This is your go-to code for a basic, flexible diagnostic look-see. It's the starting point when the doctor is just exploring and maybe does some simple specimen collection like brushing or washing. Think of this as the base code that everything else gets built on.
But, they often do more than just look. What happens when they actually take a tissue sample? Well, that's when you level up to CPT 5380. This code comes into play specifically when the physician uses biopsy forceps to grab a piece of tissue. It doesn't matter if it's one sample or a few. If forceps are used for a biopsy, this is your code. It's one of the most common ones you'll see.
Right, but it's not always that simple, is it? Procedures can get a lot more complex. So now let's dig into how we code for more advanced interventions, because these require much more specific codes to really capture the work that was done.
Probably the most common intervention you'll see is a polypectomy. Simply put, the removal of a polyp. But here's the kicker for us coders: how they remove that polyp changes everything. Not all removals are coded the same way.
And this table lays it out perfectly. If the doctor removes a smaller polyp using hot biopsy forceps, your code is 45384. But if they use a snare technique to loop around a larger polyp, then you have to use CPT 45385. You see? The documentation of the technique is absolutely crucial because the technique dictates the code.
And it doesn't stop with polypectomies. There's a whole menu of other codes for different interventions. For instance, 45381 is for an injection, 45382 is when they have to control bleeding, 45386 is for balloon dilation. You get the idea. Each of these codes tells a very specific story about what happened during that procedure.
Okay, now here's something that's really easy to forget. We're not just coding for the gastroenterologist's work. We also have to account for the supporting cast, the anesthesia that keeps the patient comfortable, and the pathology that analyzes whatever was taken out.
So when it comes to anesthesia, the million-dollar question is, who provided it? If the same physician doing the colonoscopy also administers moderate sedation, you'll be using codes 99151 and 99152. But if a separate anesthesia provider, like an anesthesiologist, is in the room providing monitored anesthesia care, then their service is billed with a totally different code, 00812.
And of course, after a specimen gets taken out, it heads off to the lab. The code you use for pathology all depends on how complex that specimen is. For a standard little polyp, it's almost always going to be 88305. But for bigger, more complex things like a section of the colon or even the whole thing, you're going to move up to higher level codes like 88307 or 88309.
All right, so far we've talked about things going pretty much according to plan, but we all know that's not always how it works, right? So what happens when things get weird? That's when we need to pull out our modifiers.
So let's take a really common what if. What if the physician starts the colonoscopy,
but for some reason they just can't finish it. Maybe the patient's bowel prep was bad, or maybe a piece of equipment failed. What do you do then?
The answer is modifier 53. This little guy tells the payer, hey, we started this procedure, but had to stop. You just tack it onto the code you would have used. But, and this is a big but, you have to have the documentation to back it up. The doctor's note must say exactly why they stopped. Without that note, you can't use the modifier.
A couple of other key modifiers to keep in your back pocket are modifier 59 and modifier 51. Modifier 59 is super useful for showing that two procedures were totally separate from each other, and modifier 51 is for when multiple procedures happen in the same session, though a lot of payers handle that logic automatically these days.
Okay, we've gone through a ton of codes and modifiers, but you know what? None of it means a thing if you're not compliant. It all comes down to two simple things: airtight documentation and following best practices.
Think of this as your essential checklist. Your coding is only as strong and defensible as the report it's based on. An auditor is going to look for every single one of these elements to justify the codes you submitted. If it's not in the report, from a coding perspective, it didn't happen. And this slide right here, this is like a map of all the landmines you want to avoid. The number one mistake, hands down, is mixing up screening and diagnostic codes. But you also have to watch out for misusing modifiers, not having enough documentation to prove medical necessity, and unbundling services that should really be included in another code. Avoiding these is the key to clean claims.
You know, at the end of the day, this is about so much more than just getting paid. It really all comes down to this quote: "Proper coding is the language we use to tell the accurate story of a patient's care. It makes sure providers are reimbursed fairly for their work, and it keeps the entire system in compliance." Mastering these codes isn't just a technical skill. It's truly fundamental to the integrity of healthcare.